Welcome everyone. Thank you for joining us. Myself, Christopher Price and Gavin Elliott will be presenting joint pain and arthritis in the primary healthcare setting. And our outline is as follows. So we're first going to start with an approach to joint pain generally in primary healthcare, and then go into more specific conditions based on the fact that what we see more often in primary healthcare. So, okay, so next slide. Just getting my notes. Okay, so why will we need to talk about joint pain? So some statistics that we've come across show that there's estimates that show that about 10% of OPD cases refer to joint pain, as well as the fact that a telephone survey in the US revealed that arthritis and chronic joint pain conditions or symptoms occur in 1/3 of all adults. In the US, there's a prevalence rate of self-reported arthritis that estimates about 60 million people. Statistics in South Africa are a bit more difficult to obtain, and what we have found is that the most prevalent form of joint pain that comes in primary healthcare settings in South Africa, including arthritis, there's a prevalence rate of 55% in urban settings, and between 30 and 82% in adults over 65 in rural settings. Now, generally what happens is that joint pain encompasses various diagnoses and different sorts of treatment, and most of them are self-limiting. So that's why there's a quick approach that we have, so we can go through it and understand how the best way to, or one of the ways in which to determine the diagnosis that we are coming across. Okay, so generally the first question that you need to ask when a patient presents with any sort of joint pain is just to find out if it is articular in the first place, because not all patients who present with what appears to be joint pain is actually articular. And generally articular pain is usually more diffuse and present in both active and passive movements, while non-articular pain is generally usually localized to the affected structure, such as the muscle or the tendon or the bursa or the fascia, nerve or the bone, and usually limits active rather than passive movement. In non-articular pain, you'll find things such as crepitus, deformity, and instability being absent, but you'll see muscle weakness. In the slide here, you can see that tendinitis and bursitis can mimic joint pain. Anything that has swelling or bruising would probably lead you to a fracture. Laxity and muscle dysfunction can include a tear of a muscle, a tendon, or ligament, and sensory changes can indicate maybe a vascular neurological cause. We've included a table on the right-hand side that's not a comprehensive or exhaustive list, but just an assistant to help determine whether it's articular or not. Next slide. Okay, so to touch briefly on the differentials of joint pain, which are quite fairly fast, as I mentioned earlier. The first point of call we thought would be a nice way to approach this is to determine whether it's acute or chronic. Acute arthralgia is defined as being 6 weeks or less, whereas chronic is obviously more than that. So we provided a list there that would show you the differentials that you can consider. Just to touch on some points, acute pain could indicate something that's such as trauma or infection, or a flare-up of chronic pain, or even the first presentation of a chronic condition. And chronic conditions can present more commonly as the arthritides that we know of, or osteoarthritis, rheumatoid disease, or crystal-induced arthropathy. Good management and the correct differentials, as we all know, is going to be based on a good history and exam. And in the primary healthcare setting, because we are limited with time as well, we found that screening to identify the area of concern can help narrow down the questioning from the history as well as the exam. We use the GAL system in terms of the screening, which I'm sure most of you, all of you know, that stands for gait, arms, legs, and spine. And some of the questions with the rationales behind them when starting off the history can be as follows: asking for pain, swelling or stiffness in the muscles and joints, finding if they can dress themselves completely or whether they can walk up and down stairs, which can focus on whether it's actually a musculoskeletal exam or whether it's the upper limb or lower limb. Okay, so in evaluation of joint pain, we all are aware of how our history. We've been doing it for many years now. But just to point on specific things in terms of the etiology. So if we are dealing with acute pain, was it trauma? If it's trauma, then you probably look at the method of injury, the ability to weight bear, to delineate the specific structures that you're going to be looking at in more detail. If it's atraumatic, then we'd actually consider something such as arthritis, infection, or even malignancy. And when it's chronic pain, it's very important to specifically ask about the onset and the progression, as well as systemic symptoms. For example, if it's involves a number of joints, it's nice to find out which joints are involved and the progression for the sequence, which joint was first, and then questioning to find out if there was a prior injury, just to determine if this is actually an acute recurring condition, so not that is becoming chronic. From the family history, osteoarthritis, rheumatic disease, and gout is more commonly seen with other relatives, so it leads you down that clue. And the systemic review, obviously based on the chronic conditions, and specifically we're looking at red flags that we need to note, such as constitutional symptoms, as well as disability that the joint pain is causing, as well as unrelenting or nocturnal pain that could lead to a more serious cause. Okay, so in terms of examination, we'll continue with the screening system using the GALS screening tool. It's a 1 to 2 minute exam, and it varies depending on whether the patient's able to stand or not, and the setting that you're in. So we're not going to go through that, but we have found a very good link that has videos as well as text in the website Versus Arthritis, where you can sort of look at that at your leisure in terms of getting more detail on the screening tool. And then in terms of the examination, it's the classic musculoskeletal exam where we look, feel, and move, looking for things such as swelling, bruising, then feeling for joint movement with there's crepitus, whether you have a doughy joint, and then examining active and passive range of movement to determine the disability. Also, based on the history and what you're finding in the exam, it's important to examine the whole patient so that we can look for other systemic signs based on the diagnosis or the differentials that you're looking at. Again, when you're looking at doing the exam, it's important to note red flags such as erythema, redness, warmth, swelling, and then something less seen is the yellow flags. So if the bruising and the joint pain is not in keeping with the history and the explanation, then you look at more sinister causes and also increase your index of suspicion to undetected abuse that may be occurring as well. Then in terms of the investigations and management, it depends on the setting that you're in. Some of the public healthcare facilities have access to radiology, so we can look at X-ray imaging if it's called for. If you're able to take blood based on the specific conditions, which we will touch on in a while, you can do that, and then lead yourself to a diagnosis in terms of them, and in terms of the management that you can have. Important to note is that the treatment goals for all patients, irrespective of it being acute or chronic, is to reduce the pain, reduce the inflammation, facilitate the healing, and try to preserve function as much as possible, and to reverse or slow the disease process. And in some cases, such as your rheumatoid arthritis, This will include early referral, so they can be started on your specific medication to prevent or slow down the progress.
Okay, good afternoon, everyone. So now we're going to move over into more specific pathologies that one can identify in the clinic. So for ease of learning, we've decided to break it down into the pediatric and adult populations. We've decided to further subdivide according to the number of joints involved. So we've divided into mono, oligo, and polyarthritis, with a monoarthritis referring to at least or just having one joint involved, oligoarthritis referring to 2 to 4 joints being involved, and a polyarthritis referring to 4 or more joints being involved. We've got a couple of examples here that go with each of those classifications, but we would like to stress that they don't necessarily have to only apply to that rule. They may also present with other features. In terms of the pediatric population, we thought that it's important to know that all pediatric patients that present with arthritis are important to work up further. So we've given a couple of important things to find on history and exam so that you might better come to an understanding of what's going on with the patient. We've identified high fever as being an important identifying tool, that being greater than 38.5 degrees. In conditions like septic arthritis, malignancy, rheumatic fever, and Still's disease, you can find high fevers. Still's disease is an inflammatory condition of uncertain etiology that usually presents with a high spiking fever in the early evening and afternoon, and is associated with a salmon-colored rash. And on the point of a rash, it's important to know that rheumatic fever and malignancy are also important conditions to consider. And if the patient has constitutional symptoms, that too may point you toward those diagnoses. It's important to identify if there's an effusion that might show you that there might be an underlying septic arthritis or hemarthrosis, particularly if there's a history of trauma, whether it be mild trauma or significant trauma. It's also important to note any systemic manifestations that you find on clinical exam, including cardiac murmur, hepatosplenomegaly, and choreiform movements. We've added a diagnostic criteria here for rheumatic fever and rheumatic heart disease as well. Important investigations to include on referral to a tertiary center include an X-ray and ECG if available, and workup bloods including FBC, CRP, ESR, and blood cultures if relevant. Once the patient has been worked up and no clear identifiable cause can be found, it's important to consider juvenile idiopathic arthritis. This is the most common rheumatological condition in children and is characterized by a chronic arthritis greater than 6 weeks duration that develops in children under the age of 16 years and that cannot be better explained by another pathology. So it is a diagnosis of exclusion. Multiple studies have been done on these children, and what they found is that there's variable expression according to gender and ethnicity, but there's been limited study in the South African population. One study that was done in the 80s in KZN found that Black and Indian patients predominantly present with polyarticular disease, and that male risk is equal to that of the females. Treatment, depending on the severity, includes supportive treatment and may extend to disease-modifying anti-rheumatic drugs that would be specialist-initiated. Physiotherapy also in more severe cases. Now we will move on to adult conditions. Here we have a few more ones that we want to consider. And as such, we have further subdivided them into inflammatory and non-inflammatory conditions.
Okay, I'll be going through the inflammatory arthropathies in the adult population. First of all, we'll look at our inflammatory monoarthritis. We'll have a look at crystal arthropathies, namely gout to start with. This is usually, is secondary to crystal deposition of uric acid within the synovium, either due to overproduction or under excretion of uric acid. 90% of patients have gout due to impaired excretion of uric acid, either secondary to chronic kidney disease, drugs including aspirin and thiazide diuretics, hypertension and hypothyroidism, and primary hyperparathyroidism. If you have a patient with a rapid onset of severe pain as a monoarthritis, often involving the first metatarsal phalangeal joint, this would pique your suspicion as long as you have excluded on history any trauma or possible features of sepsis. And the gold standard on our investigation would be a joint aspirate. In terms of management of acute gout, it's important to rest and ice the joint. Non-steroidals are also important for pain management, keeping in mind contraindications. If you do have any contraindications, prednisone can be used to manage pain, and in severe cases, also colchicine. In terms of long-term management, it's important for the patient to modify their lifestyle in terms of diet, including alcohol, red wine, beer, meats, shellfish, spinach, and also weight loss. And then if indicated, they can be initiated on urate-lowering therapy. When considering urate-lowering therapy, this can be for a patient who has frequent attacks of acute gout, more than 2 in a 12-month period, clinical or radiographic signs of chronic gouty arthritis, as well as tophaceous deposits in the soft tissues, or renal complications such as urate nephropathy or complications due to uric acid, renal stones. Then when initiating, so you initiate on 100 milligrams, not unless there is a comorbid renal impairment with GFR less than 60, then you can start on 50. And important to monitor renal function as you titrate up to achieve your target level of 0.35 millimole per liter. Then important differential diagnosis for crystal arthropathies is calcium pyrophosphate dihydrate deposition. This is also diagnosed in joint aspirations. Acute management is similar to gout with non-steroidals. However, there's no lowering therapy that can be initiated. Okay, then another differential for a monoarthritis would be septic arthritis. This is a rheumatological emergency and requires rapid intervention to avoid morbidity and possible mortality. Clinical indicators, if they do have a monoarthritis, which is often in the large joints, possibly the knee, red, swollen, hot joint, and they may have associated sinuses draining from the joint. Also to inquire about possible features of male urethritis or vaginal discharge when thinking about a gonococcal etiology to the arthritis. On the right, we have a quick differentiating table to help with the diagnosis, including age, whereas you would have a more gonococcal occurs in more younger adults and more commonly in females, as well as you would have more a migratory polyarthritis with a gonococcal septic arthritis as opposed to a monoarthritis in non-gonococcal disease. And you can also have a pustular dermatitis in gonococcal disease. Important investigations include an X-ray to rule out osteomyelitis, and then workup for the cause. And then it's also important to stabilize the patient if they are features of sepsis, give them analgesia and refer them for definitive intervention at a tertiary facility. And we'll move on to our polyarthritis, arthritides. First of all, rheumatoid arthritis. This is an autoimmune illness leading to a persistent synovitis causing progressive symmetrical arthritis. It's more common in women premenopausal, 3 times more common, whereas postmenopausal, the incidence is about the same between males and females. There are environmental and genetic factors associated with it, namely cigarette smoking. Important on history, they'll have a symmetrical peripheral polyarthritis, mainly involving the small joints, and usually the distal interphalangeal joint is spared. And then also on examination, important to look out for the hand deformities, as well as extra-articular manifestations if suspected. The more sinister ones would be pleural effusions, pericarditis, splenomegaly, indicating possible faulty syndrome. Then other extra-articular manifestations that could assist in diagnosis would be some red eyes, subcutaneous nodules, nail-folded infarcts, peripheral neuropathy, and Raynaud's syndrome. Important investigations would be FBC, looking for anemia of chronic disorder, raised inflammatory markers, and then positive rheumatoid factor and anti-citrullinated peptide antibodies. And then you would use these to make a diagnosis, for which the criteria is on the right-hand side, and one would require at least 6 points to confirm a diagnosis. Also, to aid in your investigations, you would use X-rays. You would see soft tissue swelling, joint erosions in early stages, and late changes include subchondral cysts and possible subluxation. In terms of management, it's important to manage pain acutely with non-steroidals and coxibs if available. Short-term steroids can be used if there's a persistent synovitis, preferably the lowest possible dose for the shortest duration, keeping in mind the adverse effects of steroids, and then referral for initiation of disease-modifying agents based on disease activity, which the rheumatologist will do. And then in a primary setting, it's also important to keep them involved in physiotherapy for their management. Okay, then we'll move on to the spondyloarthropathies. So the first one will be the axial arthritis, namely ankylosing spondylitis. This has an association with HLA-B27. Patients will usually be male, young, late teens to early 20s, coming in with lower back pain, pain in one or both the buttocks, as well as possible paraspinal muscle wasting on examination. Also, to do a Schober's test is quite useful to assess for lumbar flexibility on examination. And should you suspect ankylosing spondylitis, it's important to do an X-ray, but if no X-ray features are suggested or seen, such as erosion, sclerosis of the sacroiliac joint or syndesmophytes, one can use the back pain criteria, which is age of onset less than 45, that is insidious, and improvement with exercise, no improvement with rest and nocturnal pain, and 4 or more has a sensitivity of 80% for ankylosing spondylitis. And in terms of management, it's also important to manage the pain, but physiotherapy is most important to prevent syndesmophytes forming if they have not already. And then in severe forms, they can be referred for biologics at a tertiary facility. Okay, please. And then other form of spondyloarthropathy is psoriatic arthritis. This is usually associated with psoriasis. 10% of patients with psoriasis will have arthritis. It can present as either mono, oligo, or polyarthritis with similar features to rheumatoid arthritis. However, it's often asymmetrical, and the DIPs are involved. And one would see also dactylitis and nail dystrophic changes on examination. And then in severe forms, you could have arthritis mutilans, where you have shortening of the bones and telescoping on examination. And an important X-ray sign to look out for is the pencil and cup deformity, which is quite specific for psoriatic arthritis. And then in terms of management, the patients will need referral for management of the systemic inflammation. But in short term, you can use non-steroidals, however, it might worsen their skin lesions. Okay, and then reactive arthritis is the last spondyloarthritis we'll talk about. This goes with the mnemonic or the saying cont C, cont P, cont climate tree, often associated with the sexually transmitted infections or dysenteric illness, likely secondary to persistent antigen presentation in the joint. So they'll present with often an asymmetrical lower limb arthritis days to weeks after the infection. They may still have symptoms of the infection as well as possible associated conjunctivitis. The management here would be to treat the cause with antibiotics, analgesia, and then counsel the patient that the arthritis should resolve within 6 months.
Okay, and so now we're going to move on to our non-inflammatory arthritides. The most important, of course, being osteoarthritis. As we know, it's a highly prevalent condition and is degenerative in nature. It's caused by abnormal stresses and loading of the joint over time. Predisposing factors toward this condition include a history of trauma to the joint, obesity, osteoporosis, the female gender, and most specifically postmenopausal women, and those who have engaged in weight-bearing occupations. Osteoarthritis can be further subdivided into primary and secondary causes, where secondary causes are where osteoarthritis develops secondary to other pathologies that we have discussed previously, such as rheumatoid arthritis, gout, and spondyloarthropathies. Important clinical features to identify in the clinic include the presence of one or multiple joints being involved. The pain is generally described as mechanical, whereby the patient experiences more discomfort when the joint is in use. The pain and discomfort is usually gradual and progressive in nature and may or may not present with episodic inflammatory flares. Another important thing to ask on history is how long the morning stiffness lasts for, and in osteoarthritis, it's usually less than 30 minutes. Important clinical signs include decreased range of motion at the joint, crepitus, enlargement of the joint, whether that be bony or fluid, as well as joint instability and surrounding muscle atrophy. On your investigations, it's important to do an X-ray. There's 4 classic features associated with osteoarthritis, and we have an X-ray here of a knee. It's important to identify whether there's loss of the joint space, whether there is development of subchondral sclerosis or cysts, and whether osteophytes have formed in or around the joint. Management of this condition, usually supportive, including non-steroidals and mild short course opioid treatment. Lifestyle changes are important, including loss of weight, and physiotherapy and assistive devices can improve the patient's functional and life sort of condition. It's important to know when an arthroplasty might be needed. Most commonly, arthroplasties occur at the hip and knee, and indications include severe functional impairment, unremitting life-limiting pain, and severe joint destruction. Finally, we're going to go on to just a couple of important things to consider. First of all, it's back pain. We've divided up into acute, subacute, and chronic. We've identified a couple of important red flags to identify in patients with acute back pain so that we don't miss emergent conditions. On history, it's important to note whether there is any history of urinary retention, bladder or bowel incontinence, positional pain, constitutional symptoms, or any history of immunosuppressions or features thereof. On examination, it's important to look for any features suggestive of fractures, including point tenderness or stepping. It's important to note whether anal sphincter tone is maintained and whether there's been progressive weakness of the lower limbs and the distribution of any neurology if present. Also important to note if there's any clinical fever or if there's an associated pulsatile expansile mass, such as a AAA, which may present as lower back pain. Investigations to undertake include an X-ray, baseline bloods and inflammatory markers, and then more specific tests, say if you were to consider multiple myeloma, would be to do serum and urine electrophoresis. A digital rectal exam is also important in these patients, especially those presenting with neurology. Just finally, I wanted to make a note about HIV and arthritis because of the prevalence of HIV in our communities. So when talking about HIV-associated arthropathy, it is noted that it can occur at any clinical stage. It is usually asymmetrical and involves 2 to 4 joints. Most commonly, the knees and ankles are involved, and it shows a male predominance. It is usually a short-lived arthritis and is self-limiting, although it can extend into chronicity and have complications resembling that of rheumatoid arthritis. It's important to manage the underlying cause, being the HIV, and then symptomatically one can manage with non-steroidals, and indomethacin has proved particularly effective in treating this particular arthropathy. In severe cases, it also might be necessary to refer to a tertiary facility for the initiation of DMARDs, but this is definitely a specialist-initiated condition as the medication may cause further immunosuppression. And thank you very much. That's the end of our presentation.
Thank you to the team. Lovely presentation. Very good. Well done. Any comments or any questions? The joint pain is a common condition in our clinics, especially the back pain. Patients come and say, I have a back pain. So in back pain, don't forget to ask the patients for the other possibilities of that pain that could be a referred pain to the joints. Also, don't forget in the history to ask if the patient had a trauma. I'm talking in general for the joint pains. Any trauma on that specific joint, or maybe a family history, drinking and smoking also. So this is from the history, it will help you a lot to diagnose and to treat the patient properly. Any questions? Maybe people are very shy and don't want to ask any questions. Okay. I want to just highlight, there was a question 2-3 days ago on the group about signing the books, the logbooks, especially the better group. Dr. Ruiz is in Liliengoy. This week he is on leave, but next week on Tuesday he will be back. And maybe the Mufulu Clinic and Lilian, Dr. Ruiz can sign them off. Dr. Kabir is based in Chavalo. Dr. Kabir can sign the books for that site for Itirlang and maybe the Chavalo and Itirlang. Discoverers, I'm signing off the group which is finishing this week. and new group is coming next week. So do you have any questions in that regard? Because some of you maybe have done already, they have finished the rotation throughout the clinic and now doing either Beckham Langeni or a district hospital, and they're not going to come back to clinics anymore. So maybe they can be signed off this week, by the end of this week. So talk to next week, Dr. Rees can sign. Dr. Charlotte, it's Dr. Turluta and Dr. Manda. Okay, is it clear on the signing of the books? Okay, if there is no questions or comments, we can just finish with our meeting. We can close the meeting and see you next week. Keep safe and all the best.